Looking at the study combining both these large registries, I think the main predictors that we found, and probably the strongest one, is age. This is followed by prior stroke and TIA. The other interesting markers that we found for risk were using NOAC instead of a VKA or vitamin K antagonist, or using concomitant antiplatelet therapy in patients already on anticoagulation. Finally, the other slightly weaker risk factor was vascular disease. Although this wasn't statistically significant on its own, it was found to be useful in the risk model, and so was kept in our methodology as part of the risk prediction. I think the main message that we should take from these findings is not that we should use these risk scores to deny anticoagulation to patients at high risk, rather that these high-risk patients should be monitored more closely so as to avoid any potential risk of intracranial hemorrhage. In particular, I think there are a couple of things that are quite easy for us to do, and that is to avoid concomitant antiplatelet use in patients who, if they do not have a strong indication for using that together with anticoagulation. And there's a suggestion from the data as well that vitamin K antagonism may be associated with a slightly higher risk than the novel anticoagulants for that. So I think it should be used in much the same way that most guidelines recommend the use of Hasbled score, which is basically to identify patients at higher risk for closer follow-up.